Assalamu alaikum. It's a series of videos regarding obstetrics. 10 to 15 pages at a row. It's abortion. What is abortion? Abortion or spontaneous abortion is defined as unprovoked pregnancy loss. In here there is unprovoked pregnancy loss before 20 weeks of gestation is a common cause of first trimester bleeding. It's a common cause of first trimester bleeding. Spontaneous abortion are most commonly result of fetal chromosomal abnormality but are associated with congenital anomalies like teratogen exposure, Mullerian anomalies, uterine Mullerian anomalies. Spontaneous abortion are categorized based on cervical dilatation and the location of the products of conception in relation to cervix. This is missed abortion. In here, no bleeding, no vaginal bleeding, cervical os is closed, no fetal cardiac activity or empty sac. There is no bleeding. In missed abortion, product of conception is gone, no vaginal bleeding, closed cervix, the cervix is closed, and no fetal or no fetal cardiac activity or empty sac, no fetal cardiac activity or empty sac. Threat in abortion, it is giving threat, that means there is bleeding or cervical os is closed, there is bleeding, vaginal bleeding, cervical os is closed but fetal cardiac activity, baby is present, that means fetal cardiac activity is present, there is bleeding, but cervix is closed. Inevitable, there is vaginal bleeding, there is vaginal bleeding, cervix is dilated, and products of conception may be seen or felt at or above the cervical os. Product of conception is seen at or above the cervical os. So in missed abortion, there is no cervical, no vaginal bleeding, os is closed, no product of conception, no fetal or cardiac activity, sorry, no fetal or cardiac activity or empty sac. In threatened, there is vaginal bleeding, closed cervix, fetal cardiac activity is present. Inevitable is cervix is dilated, vaginal bleeding is present, product of conception may be seen or felt at or above the cervical os, at or above the cervical os. Incomplete, vaginal bleeding is present, dilated cervical os, vaginal bleeding is present, dilated cervical os, some product of conception expelled or some remain, some product of conception expelled and some remain. And complete is vaginal bleeding, closed cervical loss, and product of conception completely expelled, product of conception completely expelled. Inevitable abortion, inevitable abortion presence with vaginal bleeding, lower abdominal pain, dilated cervix, vaginal bleeding, lower abdominal pain, dilated cervix with expulsion of products of conception. Ultrasound typically reveals Ultrasound typically reveals a non-viable gestation in the lower uterine segment. Non-viable gestation in the lower uterine segment. Treatment option is prostaglandin administration or surgical curettage. Management is the choice of option is depend on patient's preference and or hemodynamic instability. So suction curettage, prostaglandin administration, threaten abortion. In threaten abortion have associated with subchorionic hematoma, collection of blood between the placenta and uterus. Subchorionic hematoma written in missed abortion, no embryo. Some early pregnancy can present with fetal pole. Repeat viability is determined by repeat ultrasound and serial diagnosis. Viability is measured by repeat ultrasound and beta ECG. Repeat ultrasound of viable pregnancy reveal continued embryonic development, and serial beta ECG normally increase until the first trimester. Decreasing beta ECG level indicate a demise. Exclude or normal pregnancy. Of non-viable. Repeat ultrasound of non-viable. Repeat ultrasound of viable pregnancy re- reveal continued embryonic development. Serial beta ECG level normally increase until the end of the first trimester. Decreasing beta ECG level indicate fetal demise and exclude normal pregnancy. Now, complete spontaneous abortion. Spontaneous abortion, pregnancy loss before 20 weeks, advanced maternal age, previous spontaneous abortion, and substance use. Treatment expectant, medical induction, misoprostol, suction curettage, infection, or hemodynamic instability. We are giving misoprostol, prostaglandins, uh, to induce the labor if not possible, suction curettage if infection or hemodynamic. Additional management, raw immunoglobulin and pathological examination. Complication is hemorrhage, retained product of the placenta, septic abortion, uterine perforation, and intrauterine adhesion. Intrauterine adhesion. Hemorrhage, retained product of conception, septic abortion, uterine perforation, and intrauterine adhesion. Septic abortion, risk factor, retained product of conception from elective abortion with non-sterile technique, elective abortion of non-sterile technique, missed or complete incomplete abortion, which is rare. Fever, chills, abdominal pain, sanguinopurulent vaginal discharge, boggy tender uterus, dilated cervix, pelvic ultrasound reported of conception, thick endometrial stripe. Septic is IV fluid, broad spectrum antibiotic, and suction curettage. Written product of conception from elective abortion with non-sterile technique, missed or incomplete abortion. Fever, chill, abdominal pain, sanguinopurulent vaginal discharge, boggy tender uterus, dilated cervix, pelvic ultrasound, written product, pelvic ultrasound. In pelvic ultrasound, there is written product of conception, thick endometrial stripe. Management is IV fluid, broad spectrum antibiotic, and suction curettage. Acute cervicitis present with first trimester bleeding. However, pelvic examination reveals a closed friable cervix with mucopurulent discharge. A cold and ectopic pregnancy typically presents with unilateral pain and light vaginal bleeding. Ultrasound presence consists of complex adnexal mass rather than simple cyst. Intrauterine fetal demise. Intrauterine fetal demise. Definition is fetal death more than 20 weeks. Fetal death more than 20 weeks. Absence of fetal cardiac activity on ultrasound. Intrauterine fetal demise is fetal death more than 20 weeks. Absence of fetal cardiac activity on ultrasound. 20 to 23 weeks. Dilatation and evacuation or vaginal delivery. Dilatation and evacuation or vaginal delivery. More than 24 weeks vaginal delivery. So intrauterine fetal death. Fetal death more than 20 weeks is called intrauterine fetal demise. Absence of fetal cardiac activity on ultrasound. Management is 20 to 23 weeks. Dilatation and evacuation or vaginal delivery. Dilatation and evacuation or vaginal delivery more than 24 weeks vaginal delivery. Complication is coagulopathy after several weeks of fetal retention. Evaluation of fetal demise is autopsy, gross and microscopic examination of the placenta, membrane and cord, karyotypes, and genetic study. Maternal is Clapper Bacchus testing for fetal-maternal hemorrhage, antiphospholipid antibody, and coagulation disorder. These are the maternal cause for evaluation of fetal demise. Intrauterine fetal demise or stillbirth is known as death of the fetus more than 20 weeks of gestation prior to delivery. Death of the fetus more than 20 weeks prior to delivery. Stillbirth. Intrauterine fetal demise should be suspected when Doppler ultrasonography failed to detect the fetal heart rate in patient with decreased or absent fetal movement. The diagnosis of the intrauterine fetal demise must be confirmed by absence of fetal cardiac activity on ultrasound. Once the diagnosis is confirmed, it is critical to inform the parents empathically as possible. Intrauterine fetal demise or stillbirth is defined as a death of the fetus more than 20 weeks of gestation but prior to delivery. Intrauterine fetal demise should be suspected when fetal Doppler ultrasound failed to detect a fetal heart rate with decreased or absent fetal movement. Cause of recurrent pregnancy loss, very high yield. It may be structural uterine fibroid adhesion, polyp, and cervical insufficiency. Uterine fibroid adhesion, polyp, and maybe cervical insufficiency. The first cause structural. Second is chromosomal aneuploidy, translocations, and mosaicism. Aneuploidy, translocation, and mosaicism. Aneuploidy, translocation, and mosaicism. Third is immunologic, that means hypercoagulable disorder and alloimmune intolerance. Hypercoagulable disorder and alloimmune intolerance. Fourth, endocrine is thyroid disease, polycystic kidney disease, diabetes, hyperprolactinemia. Thyroid disease, polycystic kidney disease, diabetes, and hyperprolactinemia. And other is advanced maternal age, defective endometrial receptivity, decreased ovarian reserve, and celiac disease. Recurrent pregnancy loss, 3 or more than 3 consecutive pregnancy loss may be associated with submucosal fibroid due to impaired embryo implantation or growth. Patients are managed with hysteroscopic myomectomy even if fibroids are not causing heavy meds, which restore normal intrauterine anatomy and reduce the risk of future pregnancy loss. Low molecular weight heparin should be given is used in recurrent pregnancy loss due to inherited thrombophilia. So, recurrent pregnancy loss, first uterine, second cervix, uterine fibroid adhesion polyp, and cervical insufficiency. Chromosomal is aneuploidy translocation mosaicism, ATM, aneuploidy translocation mosaicism. Third is immunologic hypercoagulable disorder, autoimmune intolerance. Fourth is thyroid, PCO, diabetes, hyperprolactinemia, thyroid, polycystic ovarian syndrome, diabetes, hyperprolactinemia. Another is advancing maternal age, defective endometrial receptivity, decreased ovarian reserve, and celiac disease. Emergency cervical insufficiency risk factor is collagen defect, uterine abnormalization, cervical conization, and obstetric injury. Collagen defect, uterine abnormality, cervical conization, and obstetric history. Clinical feature is two or more than two prior painless and second trimester losses, two or more than two painless and prior to second trimester losses, painless cervical dilatation. Management is cartilage placement. Cervical insufficiency is structural weakness of the cervix that predisposes to second trimester pregnancy loss. Patients usually have mild symptoms, increased vaginal discharge, light spotting, pelvic pressure, no pain or contraction, and a dilated cervix, sometimes with bulging or prolapsing membrane. Cervical insufficiency is from either inherent or acquired causes. Inherent causes include inherited collagen disorder and uterine anomaly, septate or biconvert uterus. Acquired is cervical cone biopsy, prior obstetric trauma, cervical laceration. It is diagnosed by one of the following criteria: painless cervical dilatation, it is diagnosed by one of the following criteria: painless cervical dilatation in the current pregnancy examination based, or a second trimester cervical length less than 2.5 cm plus prior preterm delivery, that is ultrasound based, two or more than two consecutive painless second trimester loss history based, which is typically present with mild symptoms, vaginal drainage, light spotting followed by precipitous delivery. Prophylactic cartilage, uh, because of high risk of recurrence, patients are treated with prophylactic cartilage, a procedure in which suture is placed to reinforce and add tensile strength to the cervix. Prophylactic cartilage is performed in first trimester in 12 to 14 weeks of gestation in patients with history of cervical insufficiency, because it can recur in second trimester. So the suture is removed at term to allow vaginal delivery. However, in patients who have bulging or prolapsing amniotic membrane, a rescue cartilage is not typically recommended due to high risk of membrane rupture, and complication is intraamniotic infection and cervical trauma. This is normal cervix, cervical insufficiency, short dilated cervix, amniotic sac bulging at os. These are the suture, cartilage. This is postpartum hemorrhage. Normal finding is transient rigors or chill, peripheral edema, lochia rubra, uterine contraction, and involution and breast engorgement. Breast engorgement, uterine contraction and involution, lochia rubra, peripheral edema, transient. Routine care, rooming in and lactation support, rooming in lactation serial examination for uterine atony and bleeding, perineal care or voiding trial, pain management. The immediate postpartum period, hours to days, is marked by physiological change, increase oxytocin level, increase oxytocin level can cause uterine contraction, which compresses increased prolactin level. The immediate postpartum period is marked by physiological changes that begin immediately after placenta. Increased oxytocin level causes uterine contraction, which compresses the placental blood vessel and protects against PPH. As the uterine envelopes, it rapidly decreases in size and becomes firm and palpable 1 to 2 cm below the umbilicus. Involution also generates subsequent lochia, which initially appears bloody with small clots and can continue for several weeks. Increased prolactin level stimulate breast milk excretion and milk let down over the course of hours to days. Infant suckling further increases maternal prolactin and oxytocin level. Decreased estrogen progesterone level may cause postpartum chills and shivering, with subsequent mild hypothermia and low-grade fever. Normal postpartum lochia, lochia rubra, serosa, and alba. Rubra is birth to 3 to 4 days of postpartum, serosa 4 to 14, and lochia alba is 11 postpartum to the 6th week. White creamy light quantity. Serosa is serosanguinous, whole blood is seen, and lochia rubra first birth to 3 to 4 days. Dark bright red, odor similar to that of the menstrual blood. Lochia may increase in quantity after breastfeeding. Suckling releases oxytocin, causing uterus to contract, and 7 to 4 days of the postpartum, which scabbing on the placental size and slough off. Heavier bleeding less than 2 hours. Lochia may also feel increased after lying down and then standing due to blood pooling into the vagina. Physiological vaginal bleeding, also known as lochia, it is normal and may last 6 to 8 weeks of postpartum. Patient often concerned about postpartum bleeding because it is heavier and prolonged than normal means. These patients should be evaluated and features concerning delayed postpartum hemorrhage. Passage of large How will you evaluate passage of large blood clot, increased fat count, and signs and symptoms of anemia. Differential diagnosis of the PPH uterine atony, very high yield. In uterine atony examination, enlarged boggy uterus, bimanual mass, uterine massage, and uterotonic drugs. If there is prolonged labor, if there is chorioamnionitis, if there is uterine overdistension due to fetal macrosemia, multiples, and polyhydramnios, in uterine anatomy there is enlarged boggy uterus. A written product of placenta, there is also enlarged boggy uterus, but placenta missing cotyledon is present and retained placenta fragments on ultrasound. In genital tract trauma, operative vaginal delivery, laceration of the cervix or vagina, and enlarging hematoma, laceration repair. Inherited coagulopathy, history of the abnormal bleeding in patient or family member, continued bleeding despite contracted uterus, correction of the coagulopathy. Then postpartum uterine atony, uterine fatigue from prolonged, induced, or precipitous labor, operative vaginal delivery, forceps assisted intraamniotic infection, uterine overdistension, multiple gestation, macrosomia, polyhydramnios, retained placenta, and grand multiplicity. A clinical feature is most common cause of PPH. Most common cause of PPH, enlarged soft bogey, poorly contracted uterus. Intervention is bimanual uterine massage, correction of the bladder distension, high dose oxytocin, tranexamic acid, carboprost, these and that. Management of the PPH due to uterine atonies. If you get soft boggy uterus, uterine massage and high dose oxytocin. Give tranexamic acid. Third is uterotonic drug like argometrin, methyl argonovin. It is contraindicated in hypertension. Carboprost, contraindicated in asthma. Misoprostol can be given. These three drugs should be told. Methyl argonovin. Methyl argonovin is contraindicated in hypertension. Carboprost contraindicated in asthma. Misoprostol can be given. Intrauterine balloon tamponade 5 is laparotomy. Estimated blood loss more than 1000 ml of bleeding and hypovolemia. This is bimanual uterine massage. This is intrauterine balloon tamponade. In PPH, more than 1000 ml of blood loss and significant signs and symptoms of hypovolemia. PPH due to uterine atony. Initial management is too large for IV, too large for IV line. For volume resuscitation and high dose oxytocin can be given. If uterine atony persists, then tranexamic acid antifibrillary lytic should be given if administered within 3 hours of delivery. If continued bleeding, second line uterotonic medication carbapenem, methyl argonovin, misoprostol can be given. Methyl argonovin contraindicated in hypertension due to increased risk of stroke. Methyl argonovin contraindicated in hypertension due to increased risk of stroke. If PPH do not resolve, balloon tamponade. Finally, PPH may finally uterine artery embolization and surgical possible hysterectomy should be done. In retroperitoneal hematoma typically occurs within delivery. Within hours of delivery, uterine atony is the most common cause of backside retroperitoneal hematoma. Retroperitoneal hematoma is a rare but life-threatening cause of PPH. Presence with no incisional bleeding and minimal or abdominal back pain. Hemodynamic unstable patient with suspected retroperitoneal hematoma require emergency laparotomy. CT scan of the abdomen and pelvis can confirm the diagnosis of the retroperitoneal hematoma, but is only appropriate for hemodynamic stable patient. Stable patient may then undergo arterial embolization. That's all about this. Hope you enjoy.